we could spend several days on. Sorry, I had to figure out how to advance my slides. Why does it not allow me to advance? Oh, let's see. Oops, sorry. Let's try again. Doesn't want to allow me to advance for some reason. Let's see. More. I'm not sure. Okay, there we go. All right. Not sure how I did that. Okay. All right. So today, primarily what I'm going to talk about, like I said, is some controversies regarding pediatric sleep apnea. And I really tried to keep this talk evidence-based. And specifically, I'm going to focus on the treatment of mild sleep apnea, severe sleep apnea, and then persistent sleep apnea. And so I've included some recent references, and I'm happy to share those at the end of the talk. So I also thought, just to keep it more interesting, I'd make it case-based. So this is the first case in a 5-year-old who's presenting with snoring, tonsil hypertrophy. Sleep study shows an apnea-hypopnea index of 2.9 with an nadir oxygen saturation of 94%. And so what is the most appropriate treatment? Observation, montelukast or Singulair, or adenotonsillectomy? And, mild sleep apnea in children is still, in terms of management, a very controversial topic. If you ask, 3 different pediatric sleep, kind of specialists, you probably get 3 different answers. And so really, I think part of the reason is that we don't have a lot of good data on the natural history of sleep apnea in children, and that makes it difficult to treat. Traditionally, when we have treated mild sleep apnea, it's been mostly for quality of life issues, behavioral problems, that kind of thing. But there's some recent data now to suggest that there may even be some cardiovascular implications, but again, just don't have a lot of evidence. But certainly all of those treatment options are reasonable for mild sleep apnea, whether it be watchful waiting, some different anti-inflammatory medications, or adenotonsillectomy. So in terms of medical management, there's now been numerous studies published looking at intranasal steroids, such as Flonase or Nasonex. This particular slide shows a well-done randomized placebo-controlled trial where they looked at mometasone for 4 months, and they did find that children that got the mometasone were more likely to have improvements in their AHI, although it was just from 2.7 to 1.7, so you can question how clinically significant that is. Not surprisingly, they did find children in this group that had allergic rhinitis were more likely to respond to treatment with nasal steroids. So the real limitation of this study, and really with most of the studies we have on medical management of mild sleep apnea in children, is regarding the duration of therapy. Most of these studies are short-term, so anywhere from 3 to 4 months. And we don't know what happens when you stop the medication afterwards, or really how long should you treat them? Should you treat them for 6 months to a year? And so that's definitely something in the future we need to look at. Probably one of the biggest advances in medical management in the past decade or so for mild sleep apnea, the kind of discovery that Singulair does seem to significantly improve AHI. This was one of the first trials that looked at Singulair in the treatment of children with non-severe sleep apnea, which in this trial they defined as an obstructive apnea-hypopnea index is less than 10 on sleep studies. Again, a really well-done trial. This was another randomized, double-blinded, placebo-controlled trial that was published in Pediatrics, and they took 46 children and they treated them for 3 months with either the Singulair or montelukast or placebo, and they found that there was a significant reduction in the apnea index. And they also did lateral neck x-rays in all of these children, both pre and post-treatment, and found that the Singulair group was more likely to experience a reduction in adenoid size. So there have been some recent studies that have shown that we do think that there are leukotriene receptors on both adenoid and tonsillar tissues, and that is the thinking as to why Singulair, which is a leukotriene modifier, might be effective in treating these kids. This is another study looking at Singulair. Again, this study was a retrospective study, so not as high quality, but I included it because it was a very large number of children. It was multi-institutional. They had 691 children that had mild sleep apnea. All of these kids, again, had sleep studies at baseline, showing an AHI of 1 to 5, and then they were treated with 3 months of Singulair. And also, in this case, they were also treated with a nasal steroid, so it was combination therapy. And what they had, they had 445 children that repeated their 3-month sleep study. And basically what they found was about 60% of the population seemed to do well with the medication. They had normalization of their sleep study. They did find that about 30 to 40% of children after that 3-month period either had persistent obstruction or increasing obstruction, and so those children went on to have an adenotonsillectomy. So what I liked about this study is they looked at which factors predicted treatment failure, and they found that older kids, so 7 and older, and those that were obese were less likely to respond to medical management. And so I have also seen that in my practice. Medical management with Singulair often does work better for younger children. I have not had as much success with older kids. So one more paper about Singulair before we move on. So I mentioned the main reason we typically treat mild obstructive sleep apnea is, for quality of life, symptoms, snoring, things like that. And so many of these studies, as I mentioned, just show very small differences in the AHI, between 3 and 1. And so my question was, symptomatically, how did these kids do? I've done a lot of research on outcomes and quality of life, and this is what is more important to parents, right? They don't care as much if the sleep study score changes by 1 or 2 points. They want their child to sleep better, have better behavior, and be less tired during the day. And so we designed a prospective study to look at children with mild sleep apnea and specifically examine how their quality of life changed after we treated them with 4 months of Singulair and Flonase. The primary instrument that we used for this study is the OSA 18, and that's, for those of you who are not familiar, it is a disease-specific validated quality of life survey. It's 18 questions long. It's been translated into multiple different languages. It's used across the world. And I think it's the most commonly used instrument to assess quality of life, not diagnosis of sleep apnea, but just assessing how the child's snoring and sleep apnea impacts their daily life and the daily life of the family. And so for this study, we did the OSA 18 at both baseline and at 4 months. And we had 31 children that we enrolled. About 50% of our patient population was obese with a mean AHI of 2.8. So overall, very mild disease. And their baseline scores for their OSA 18 were 60.2. So in the OSA 18, I think I do have a picture of it later, higher scores indicate poorer quality of life. So there was a significant improvement following 4 months of medical management. So a score for the OSA 18 of 40 to 60 typically indicates a mild impact of sleep disturbance on quality of life, whereas a score of 60 to 80 is severe. And so we went from more of a moderate to a more mild impact with the use of the Singulair. So interestingly enough, there were 4 children who had to discontinue the Singulair because of behavioral side effects. And really, this was the first study to report in terms of using Singulair or montelukast to treat sleep apnea in children, these behavioral side effects. There's actually a fair amount of data from the asthma literature looking at some concerns regarding depression, and even in older adolescents, there was some concern for suicide. And so recently in the US, the Federal Drug Administration did put a black box warning on Singulair in regards to taking care to use it, especially in children that may have a history of mental health disorder. And so for me, that black box warning, I think, came out about 3 months ago. I still do use Singulair a lot in my practice, but I specifically now ask in older children about mental health history, and if they have a history of any depression or anxiety, I do not offer them Singulair. I think for younger children, I think it's fine to use it. I do counsel parents that if they see any changes in behavior, and most commonly it's aggression and irritability, they should stop the medication and then it goes away. I do think it happens more commonly in kids that have underlying behavioral problems, but it's just something to be aware of if you are going to use Singulair to treat these kids with mild disease. So ultimately, we had about 20% of our patients that did not seem to respond to medical therapy, and they underwent adenotonsillectomy. It was a small group, but we did try to look to see what factors, if any, predicted failure, but we did not see anything such as obesity or age. Now, obviously, the primary limitation of this study is that we don't have a control group. So we could say maybe these kids would have had an improvement in their quality of life even if we didn't treat them. I don't think that's the case. We'll talk about the CHAT study later. The children in the CHAT study, which is the childhood adenotonsillectomy trial, those that weren't treated in that study continued to be fairly symptomatic in the observation group. So I do think there's something to the improvements that we saw in this study. So again, this is can't talk about mild sleep apnea without mentioning the childhood adenotonsillectomy trial, or the CHAT study. And this was really kind of the landmark study published back in 2013 regarding treatment of pediatric obstructive sleep apnea. We've done adenotonsillectomy for sleep apnea for years and years, but really did not have a high quality randomized trial looking at the efficacy of this treatment. And so the CHAT was, again, multiple different institutions across the US. They enrolled children who had an apnea-hypopnea index greater than 2 and less than 30 on baseline sleep studies, and kids were between 5 and 12 years of age. And the reason that they chose this age range was because of they did some neurocognitive testing, and that was the age that was appropriate for the neurocognitive testing. And these kids were, again, either randomized to a 7-month period of watchful waiting or to early adenotonsillectomy. They underwent a whole battery of assessments, both at baseline and then again at 7 months of follow-up. The very interesting thing about this study was that they had to exclude a significant number of children because their AHIs fell less than 2 on the sleep study. We're talking about otherwise healthy, non-syndromic children. Many, many kids had AHIs less than 2, so they actually had some difficulty recruiting, which I thought was very interesting. So many of the otherwise healthy children that we're probably operating on have AHIs less than 2. Anyway, average age was 6. Their main finding was that there was no change in the neurocognitive assessments between the two groups. So meaning having your tonsils and adenoids out in children with overall mild disease, because again, the median AHI in this study was only 4.5. So we're talking about a group of kids that did not have severe disease, but really there was no cognitive benefit for these kids after 7 months. In terms of sleep study outcomes, quality of life behavior, the surgery group definitely did much better than the observation group amongst all those outcomes. The other interesting thing about this study was when they repeated the sleep studies after 7 months in all of the children, they found that almost half of the kids in the baseline group, meaning the observation group, had normalization of their sleep studies. So their AHI went to less than 2. Children that were at risk for persistent disease were those that were Black, those that were obese, and those that had a higher AHI. So ones that had a higher AHI greater than 4. Those were the kids that did poorer in this study. So there were some limitations. As I mentioned, the age range was 5 to 12, so we don't have good data on kids that are younger than that. Can we really extrapolate to kids that are 3, 2, and 3? And then also for adolescents, they excluded those. And maybe 7 months is a relatively short time, so maybe we would see differences in neurocognitive outcomes if we looked further out in terms of 1 to 2 years. So certainly someone may argue, well, if 50% of children with mild obstructive sleep apnea are going to have normalization of their sleep study, meaning after 7 months, their sleep study is going to be normal. Why should we operate on them? Why not just wait? And so I included this study to kind of just create a bit of controversy. But this study, again, came out of the CHAT group. They published probably 20 papers based on their data set. And this study specifically looked at children who were in that watchful waiting group. And what they were trying to do was figure out which factors predicted which children in the watchful waiting group would go on to get better, okay? And I thought this was very interesting because, again, we don't have a lot of history or information on natural history. So there was 194 kids in this watchful waiting group. And again, overall pretty mild disease with an AHI of 6.7. And they found that almost half, similar, had resolution of their AHI to less than 2 after 7 months. So, but when they went and looked at actual symptoms and quality of life, and the main symptom score they were using was the pediatric sleep questionnaire, they found that only 15% of subjects actually had improvement in their symptoms as reported by the parents. So even though these sleep studies, they're improving in terms of their sleep study, they really are not improving in terms of their symptom burden, whether it be poor sleep, behavioral problems, and daytime sleepiness. They did find, in this study, that habitual snoring, if you had habitual snoring, you were less likely to improve with watchful waiting. And so, what I think we can conclude from this study is that watchful waiting is certainly an option, but we need to make sure we're counseling families that if they choose that option, they are still likely to have their children snore and to see some of the problems with sleep and behavior. That's not likely to resolve, even if their sleep study improves. So one more paper I wanted to talk about for mild sleep apnea before we leave. This is a study that we did at our institution several years ago now. And again, we were interested in looking at adenotonsillectomy versus observation for children with mild obstructive sleep apnea. We actually had a much broader age range than the chat. So we included kids from 3 to 16 years of age. And these were healthy kids. We excluded children with syndromes and other significant medical problems. And really the main thing we wanted to look at again was quality of life, because that in my practice is what parents really seem to focus on, how their child is doing in school, their daily lives, and how they're sleeping. And so that was the main focus of our study. We actually used the OSA 18 again, and then we used a more global quality of life assessment called the Children's Health Questionnaire. But I'm going to focus primarily on the OSA 18 because that's something that you can incorporate into your practice. So initially I wanted to try randomizing, but parents in Virginia don't like to be randomized apparently. And so we allowed parents to choose whether they wanted to go into the observation versus the adenotonsillectomy group. This is the quality of life survey that I mentioned, or that we've been talking about. And again, you get a total score. It has a Likert scale, so 7 different options the parents can choose. It's very easy for the parents to fill out, and you get both a total score by just adding up the columns, or you can get subscale scores based on sleep disturbance, physical symptoms, emotional symptoms, daytime function, and caregiver concerns. And so I have a slide in a few minutes, but I would encourage you guys to use this in your practice if you're not already. I find it very useful when managing mild sleep apnea. So this was the demographics from our study. We see we had about 64 children, half in the surgery group, half in the observation group. Again, overall, very mild disease with an AHI around 3. So when we look at the OSA 18 scores, this is at baseline here, you can see for surgery, not surprising, they have a higher score. And it makes sense that parents of children who are more symptomatic, who have poor quality of life, are more likely to opt for surgery initially. You can see the observation group, they were a little less affected. So when we look at early follow-up, so that's 4 months from our baseline, we see the surgery group is doing much better. So at early follow-up, there was significant improvement, and the surgery group is doing better than the observation group. Now, when we look, however, out to our 7 to 8 month follow-up, we can see the surgery group still, in terms of their quality of life, maintaining the significant improvement that they've had since surgery, but there was a trend for improvement in the observation group as well. And so some of these kids experienced improvement in their quality of life, so much so that the difference between the surgery group and the observation group at 8 months was less significant, or was not statistically significant at least. And so the only other thing we did report on when we did this study was there were 6 children, again, that initially were in the observation group. The parents decided they got worse, and they didn't have any differences from the rest of the group in terms of age, gender, obesity. But the one interesting thing we did find is when we went back and we looked at their total OSA 18 quality of life scores, those that were in the failed observation group, meaning the parents said after 3 to 4 months, I think my child's worse, I want tonsillectomy now, they actually had higher baseline OSA 18 quality of life scores when you compared them to the rest of the group. And so what we concluded from this study is that There are, again, some children with mild sleep apnea that really do seem to have a significant impact in terms of their quality of life due to their poor sleep, and that the quality of life definitely improves after surgery. And certainly there's a group of kids that will get better on their own, and those tend to be less symptomatic. And so you can really use the OSA 18 in your practice to help guide how you want to manage these patients. So for me, everybody now who has mild obstructive sleep apnea who comes into my practice has an OSA 18. They fill it out. It takes only 5 minutes while they're waiting for me. And then if their score is greater than 60, I tend to be more aggressive in their management, either offering them medication versus adenotonsillectomy. And when I now have these conversations with parents, I really use a shared decision-making model. I lay out all the different options for them, and then we discuss what they think is best for their child and their family. But the OSA 18 has really been very useful in guiding that discussion as to how aggressive our management we want to pursue. All right, so let's move on then, and we'll talk about severe obstructive sleep apnea now. So another case just to discuss, we have an 8-year-old male. He presents with snoring, tonsillar hypertrophy, and he had an apnea-hypopnea index of 41 on a recent sleep study ordered by his pulmonologist. And there was a nadir oxygen saturation down to 76%. So what would be the most appropriate treatment? So your options are CPAP, adenotonsillectomy, and drug-induced sleep endoscopy with adenotonsillectomy, and possible palatopharyngoplasty. So again, this is a rather controversial topic, and we know that, again, adenotonsillectomy is the primary treatment for pediatric sleep apnea, but we also know that there is a high rate of failure, especially among certain groups of kids. Again, we talked about kids that are obese, kids that are Black, kids that have more severe disease at baseline, and those that have significant syndromes such as Down syndrome are all going to be at increased risk for failure of adenotonsillectomy to improve their sleep apnea. We also know that as we've done more sleep endoscopy, and sleep endoscopy is a whole nother topic in kids that I could spend, an hour discussing. And so I have a little bit in here today, but I just didn't have time to put it all in. But as we've been doing more and more sleep endoscopy in children, we have seen that children with severe obstructive sleep apnea tend to have multi-level collapse. Unlike children with milder disease, where their collapse is typically just tonsils and adenoids, many of the children with severe disease have multi-level collapse. And so my question is, can we improve our adenotonsillectomies outcomes if we do multi-level sleep surgery? It's a very controversial stance. You have some pediatric sleep surgeons who say, just do an adenotonsillectomy, and then if children fail, bring them back. But I tend to be in the camp that your first surgery, I'm a little bit more aggressive about doing multi-level surgery at the time of adenotonsillectomy in children with severe disease. But again, not very, very little data to support that position, other than my clinical practice and what I've seen. So there was this study that was published out of Texas several years ago, and as many of you may be aware, UPPP was commonly used in adults for sleep apnea for many, many years, but has largely fallen out of favor and has been replaced by different palatal techniques that focus more on muscle rearrangement. And certainly the expansion sphincter pharyngoplasty is one such technique. This particular author did a modification, which I'll talk about, of the pharyngoplasty. And what he did was he looked at his outcomes from children that had had severe disease. So he defined that as an AHI greater than 20 that were having adenotonsillectomy. He did a sleep endoscopy when they were having their adenotonsillectomy, and if they had significant lateral pharyngeal wall collapse, which is the primary, which is what the pharyngoplasty is primarily used to treat, then he went ahead and did the pharyngoplasty at the time of the adenotonsillectomy. And so, again, this is one technique, and there's many, many different techniques. I'm sure some of you have seen Tucker Woodson or Ed Weaver describe it, and they often change their techniques. But basically, for this particular paper, they were transecting the palatopharyngeus muscle here, and then creating a tunnel up here, up under the palate, and then suturing that palatopharyngeus muscle up here so that you got significant lateral superior pull, which you see here on the right with the left here still being down. And so he had 25 children, so very small study. But when you looked at his AHI, there was significant improvement. So the kids started out with very severe disease, 60.5 was their mean AHI, and he saw improvement to 2.4. 64% of these kids actually had an AHI of 1 after he did his adenotonsillectomy and pharyngoplasty. So certainly impressive results, but again, we don't have a control group, so we can't say maybe these kids would have done better without it. But for me, I definitely do use this technique, especially in older children, so obese adolescents that have severe disease, that have tonsils that aren't as large. When I remove the tonsils, I will often do a concurrent pharyngoplasty, and I've had very good success with that. So this, the other main site of obstruction that I've seen a lot in my patients is this anterior-posterior palatal collapse. So you see the tonsils are collapsing laterally there, but also you see that there is some anterior-posterior palatal collapse. And I've seen that on a lot of these drug-induced sleep endoscopies, and that's a lot harder to address surgically. We talked about the pharyngoplasty addressing lateral collapse, but often tonsils, removing the tonsils will also address lateral collapse. And so what about these kids that have anterior-posterior collapse? And so I've come up with this stitch, which we call here we go. Oh dear. All right, hopefully it's gonna load. There we go. It's called I just call it the palatopharyngoplasty stitch, but it involves taking a bite of the palatopharyngeus muscle and then coming up through the midline, through the palate, the muscle, and the mucosa there. You go back down through the midline with the same stitch and exit through the anterior portion of the palate. It's running. There we go. Let's see. Come on, you can do it. Oh dear. Let's see. We'll try one more time. It's a big video file. Okay, again, so this up through the midline of the palate again, and then we're going to go back down through the midline of the palate, and that is really where we get the doesn't like me. That's really, there we go. That's really where you get the anterior posterior elevation, and then the next part of the stitch is going to go out right there towards out laterally superiorly towards the hamulus, and then you're going to come back down and come back out the anterior portion of the soft palate. And then once you tie it up, again, you get a little bit of lateral superior pull, but mostly this is for anterior posterior palatal collapse. And you'll see that it really elevates right off the posterior pharyngeal wall. So, okay, let's move on. Okay, so we looked at our results. So I've been doing this stitch now for a few years, and we went back and looked at children that had the palatopharyngoplexy stitch. And again, I was doing this on children primarily at the time of adenotonsillectomy who had this anterior posterior palatal collapse that had mostly severe disease. I have done it on a few children that had persistent disease after adenotonsillectomy, but I did not find it was as effective. I think this works better when you do it at the time of adenotonsillectomy. But overall, our patient population, we saw there was a significant improvement in their AHI. Interestingly, we found that children that had tongue-based collapse on their DICE or on their sleep endoscopy were less likely or were more likely to have persistent disease even if we did do the palatopharyngoplasty. We didn't have any complications such as VPI or hemorrhage. So again, same limitations of our trial. It was a retrospective review, but we are currently conducting a randomized trial. We have right now about, I think, almost 40 children enrolled. Half of the children, they all have severe disease, so AHI greater than 20. Half of them have undergone adenotonsillectomy, and the other half were randomized to undergo adenotonsillectomy plus the stitch that I showed you. And so we're very interested to see if we can improve outcomes by doing this stitch, which is relatively simple. It takes only 5 minutes a side. The stitch I was using to do that is just a 3/0 Vicryl. on a taper. And so if this does indeed improve outcomes, I think it could be a game changer in terms of helping some of these kids with more severe disease. And so hopefully in another year or two, I can come back and give you the results of that. So before we leave management of severe sleep apnea, I wanted to mention turbinate reduction. So turbinate reduction in adults, we know, doesn't necessarily improve apnea-hypopnea index in terms of outcomes. But in children, really the jury is still out on that. There's very little data about inferior turbinate reduction in the treatment of pediatric obstructive sleep apnea. This is one study that was out of China, and basically what they did was they took children who had both sleep apnea and allergic rhinitis, which they just described as nasal obstruction that failed medical management. And at the time of the adenotonsillectomy, children that had persistent allergic rhinitis, whose parents chose to have the turbinate reduction, had it. And then they also had a group of children who did not have turbinate reduction. They were not randomized. It was just based on parent preference. But overall, they had 23 children in the adenotonsillectomy turbinate group and 28 children in just the adenotonsillectomy group. And what they did find was that the AHI in the adenotonsillectomy plus turbinate group had better improvement. So the postoperative AHI in the turbinate group was 0.8 compared to 3.5 in the adenotonsillectomy group alone. Again, very small changes, but in my practice, I have really found that turbinate reduction can make a big difference in terms of the treatment of sleep apnea. So I now am much more aggressive, especially in my older adolescents that have big turbinates. I'm very aggressive about reducing the turbinates at the time of the adenotonsillectomy. I will say that I had one 2-year-old recently, and it's, again, just an anecdotal report, but she had prior adenotonsillectomy, had an AHI initially of 40, but still had persistent AHI of 20 on her repeat sleep endoscopy. And the only thing I saw on her sleep endoscopy was enlarged turbinates. Mom said she breathes all the time through her nose or through her mouth. She was really suffering. So I did a turbinate reduction on her, and her repeat sleep study showed an AHI of 2. So, again, it's a single case, but I do think that there, as we do more research, we will find that the turbinates may have a larger role in terms of obstruction in children than they do in adults. So at our institution, we just finished up a randomized trial in which we looked at adenotonsillectomy versus adenotonsillectomy with turbinates. At the time I did this trial, I was using coblation. I'm not using coblation anymore. I didn't think it was particularly I didn't think it was aggressive enough. It didn't have as good a result. So I had switched over to using a microdebrider and also out fracturing. Now that was before the COVID pandemic. So now I'm not sure what we're going to use because, as many of you know, right, we worry that the microdebrider causes significant aerolization. But prior to the COVID pandemic, I had switched to the microdebrider as my instrument of choice for turbinate reduction. But when I was doing this study, I was still using the coablator. The main point of this study was not to look at sleep apnea outcomes, but again, was more looking at quality of life to see if we reduced the turbinates at the time of adenotonsillectomy, children had more improvement in their congestion than if we just removed the adenoid alone. Again, we looked at the SN5, which is a quality of life score that's more based on nasal symptoms than the OSA 18. And what we found, we had 50 patients overall, and we saw that both groups, whether you had adenotonsillectomy or adenotonsillectomy plus turbinates, both groups did well. And so again, I don't know if that's just because I wasn't being aggressive enough in my technique, or maybe there's not necessarily some additional benefit in terms of quality of life. But I definitely think more research is needed to determine what the role of the turbinates is. For me right now, if I have an obese, older child that has severe disease, I'm going to usually do a sleep endoscopy, adenotonsillectomy, and I will do a pharyngoplasty if the palate does appear to be obstructive, and I will also do their turbinates at the time. And I've had really good results in treating, some obese adolescents with AHIs even in the 70s, 80s, 90s that you would think surgery would not, necessarily cure. So, but again, we need more data. All right, so the last thing I want to talk about is persistent sleep apnea. This is a 7-year-old male, comes in with snoring and sleepiness. He had already had prior adenotonsillectomy 2 years ago, but he still has significant persistent disease with the recent sleep studies showing an AHI of 16. And so what would you recommend as the most appropriate treatment for him? Do you do CPAP? Do you do UPPP or sleep endoscopy? And again, very controversial topic. There's many different ways. Certainly, we can treat persistent sleep apnea, and I think CPAP definitely has a role. And I will offer all of my patients that come back that have persistent disease, I'll offer a CPAP treatment, but it is sometimes difficult for children to tolerate, and especially the adolescents don't want to be bothered with it. And so since we've been doing drug-induced sleep endoscopy, I think we've had significant advances in surgical management of this population. I'm not going to talk about orthodontic treatment or myofunctional exercises today. I'm just going to focus on surgery just because of the interest of time. But when we look at the data on surgical management of persistent OSA in kids, again, very sparse data. Stacy Ishman did a meta-analysis a few years ago and really found that most of the studies that exist on persistent OSA in children are small, single institution retrospective reviews. And so we really do need more data. To that end, there's a group of us that are putting together a database to try to examine outcomes in this group of children to see if we can improve the level of evidence that we have. So again, I don't have a lot of time to talk about DICE, but sleep endoscopy really changed the way that we were able to focus and manage these children with persistent disease. Many of you are aware, in adults, DICE has been, or sleep endoscopy has been performed since the 1990s, and so most people will use the VOTE, and there's pretty standardized protocols, whereas in children, the routine use of sleep endoscopy is newer, and so there's still a lot of controversies. How you score. And so just as a little teaser, the American Academy of Otolaryngology did decide to sponsor a clinical consensus statement. And so we are just finishing up. I chaired writing the clinical consensus statement on pediatric sleep endoscopy. So we're just finishing up the manuscript. We're hoping to present the findings or the key action statements at the annual meeting, if it still is happening in Boston. But if not, we'll hopefully publish that paper sometime in the next few months. And it addresses a lot of the different controversies and provides some more guidance about sleep endoscopy in children. So be on the lookout for that if that's an area of interest to you. So the primary surgery that's used to treat persistent obstructive sleep apnea in children is lingual tonsillectomy. And we have noticed on drug-induced sleep endoscopy that tongue base, whether or not it's due to lingual tonsil hypertrophy or not, is one of the most common sites of residual obstruction in children after they've had their tonsils and adenoids removed. So what exactly causes lingual tonsils to enlarge? We don't know. We certainly know that children with Down syndrome are much higher risk for having significant lingual tonsil enlargement. We also think that reflux may play a role. And we wonder if us removing the tonsils and adenoids initially causes some sort of lingual tonsil, excess growth. And so maybe it's, us as the providers that have caused some of this. But in any case, typically when we remove the lingual tonsils, it's done transorally, and you can either do an excision, or excuse me, you can either do it similar to how you would do a DLB with placing the patient in suspension, or you can do it with a mouth gag and use an angled scope and remove it that way. So there's all different techniques, but I think the coblator is really, I do not use the coblation for my regular tonsils because it's expensive and I don't see really a huge benefit, but I do think where the coblator excels is in for the lingual tonsillectomy. When we used to use the microdebrider and the laser, there was a lot of charring and a lot more bleeding, and so I found that coblation is very effective for lingual tonsillectomy in children. Overall, in terms of complications for lingual tonsillectomy, it's similar to your regular palatine tonsillectomy, with the exception of if you get too deep, you can get into the lingual artery, and there have been some case reports regarding that. The other thing in terms of lingual tonsillectomy, Cincinnati published this study several years ago looking at several cases of oropharyngeal stenosis that happened at the time of adenotonsillectomy, or excuse me, that happened following lingual tonsillectomy. And so what they found was that in children that were having lingual tonsillectomy, that were having multi-level surgery at the time of their lingual tonsillectomy, that there was a risk of oropharyngeal stenosis. So from my standpoint, I would not recommend that you ever do a lingual tonsillectomy at the time of you do a regular palatine tonsillectomy, because that child would be at very high risk for stenosis. You would want to stage that. Who just had tonsillectomy and adenoidectomies that developed oropharyngeal stenosis. But in my practice, I do lingual tonsillectomies at the time of revision adenoidectomies. I'm just very careful to stay midline for both, and I have not had any problems with that stenosis. So this is just a picture. This was actually a very young child with Down syndrome, but you can see the epiglottis here. This was a sleep endoscopy photo. The epiglottis is infantile in appearance, but there is some tongue base that's really pushing that epiglottis back, and so that's just us using the co-ablator. I prefer to do this, I also love airway surgery, so I prefer to do this using a suspension and a laryngoscope. As a pediatric otolaryngologist, that's just my preference. But this is the other technique. This is one of the first papers published by Peter Koltai that looked at lingual tonsillectomy in children with persistent disease. He uses a mouth gag and then uses the angled scope. And in the bottom figure, you can see he's done 1/2 of the lingual tonsil. And overall, these kids do pretty well. He shows he's reporting RDI here instead of AHI, but there was significant reduction. We have seen, though, in many of these papers that look at lingual tonsillectomy, that there are still kids that have persistent disease. So this may not be a cure-all, but often we do get some improvement. So let's move on to talk about laryngomalacia. So as we've been doing, again, more sleep endoscopy, laryngomalacia, what we call either occult laryngomalacia or sleep-dependent laryngomalacia. This really was kind of discovered as we did more sleep endoscopy in children with persistent disease. So we're all familiar with regular congenital laryngomalacia, newborns with stridor, but in the sleep-dependent laryngomalacia, really many of these kids do not have airway symptoms. This is really you only see the laryngomalacia at night and when they sleep. And so we're seeing more and more kids now undergo supraglottoplasty for the indication of persistent obstructive sleep apnea. This was one study that looked at, again, a small retrospective reviews, which is really all we have. These were children that underwent supraglottoplasty after they had a sleep endoscopy showing that they had sleep-dependent laryngomalacia. Most of these patients had a prior TNA and had persistent disease, but they saw significant improvement in their AHI from 13 to 4.1. And again, very low complication rate. There was some dysphagia, but this resolved shortly after surgery. There was recently a larger systematic review looking at supraglottoplasty outcomes for children that had sleep-dependent laryngomalacia. There were only 62 children that total, even with a systematic review, so that tells you that, again, there's not a lot of data, but they did find that there was significant improvement in the apnea-hypopnea index. So really, they didn't mention what factors improved outcomes. And so in my practice, I was very excited when this first came out about, I have no idea why there's yellow scribbles on there. Sorry. I was very excited when this first came out to look at, to hopefully cure more people with doing supraglottoplasty, but I have not found that laryngomalacia, sleep-dependent laryngomalacia, is a huge source of obstruction in the majority of children. Where I have found it is in young infants that have significant sleep apnea. The supraglottis is often a site of obstruction, and I've found it in our children that have hypotonia, some of our CP kids. Those are the kids that I think are more likely to have the sleep-dependent laryngomalacia. So in terms of geneoglossal advancement, many of you may be familiar. It used to be called the Repos system, but now Medtronic bought it. There's some other systems out there as well. But you make a small submental incision over the genial tubercle, and then you put an anchor there, and then you put a large stitch through the tongue base to bring it up. Let me see if I can fix this. I have no idea why there's this.
You have to disable the
I thought I did that.
annotation.
Let's see. Clear.
Anyway,
Yes. Okay. Okay. In terms of the Genioglosal advancement, again, very little data on this. There was one study by Sally Schott in which she looked at genioglosal advancement, and she did radiofrequency base of tongue reduction at the same time. And most of the children in this study had Down syndrome, so over 50%. And she did see an improvement in the AHI from 14 to 6.4. And so again, some benefit for these kids, but many of them still had persistent disease. Oh, why? Okay. Midline glossectomy. This is an older slide to the left showing the SMILE procedure, which was a submucous or submucosal resection. Most people have gone away from that because of the lingual artery, but in terms of doing midline glossectomies, you want to stay fairly posteriorly and midline if you're going to do it to avoid the lingual artery. I have done some of this in my practice, but have not had great success. I think that it may improve the AHI some, but it's not been very successful for me. This was a study out of, again, this is by Wooten out of Vanderbilt, and he looked at his population of children that had undergone midline glossectomy. Many of these kids had Down syndrome, and he did find there was some improvement in the AHI, although interestingly enough, these kids had very mild disease to begin with, AHI of only 7. And so I really think that midline glossectomy is actually going to become less and less prevalent, definitely in terms of kids, and it's going to be replaced by the hypoglossal nerve stimulator. And so this is, I think, going to be the future of therapy for children that have persistent disease that have significant tongue-based collapse. And so, as many of you may be aware, the hypoglossal nerve stimulator, there's currently only one approved for use in the that's FDA approved for use in the United States, and that's the Inspire system. And so the Inspire system is a paced system. So you'd have the neurostimulator that's implanted in the chest wall just below the clavicle. So that's one incision there. And then you have the lead that goes to the hypoglossal nerve. So you have a second cervical incision to place that lead with a little cuff around it. And then you have a third incision where you have the sensing lead that's placed in the intercostal musculature. And actually, for adults now, we have good 5-year data. So the STAR trial is out to 5 years now, and it shows sustained efficacy and significant improvement in appropriately selected patients for this therapy. So this is just an intraoperative photo showing the cuff around the hypoglossal nerve on the bottom left, and you can see the significant stimulation of the genioglossus with inspiration to protrude the tongue when you turn the device on. So Dr. Chris Hartnick, who's at Mass Eye and Ear, received approval to do to start a study looking at children with Down syndrome specifically that had persistent obstructive sleep apnea, that had tongue-based collapse, which is the primary site of collapse in most children with Down syndrome that have obstructive sleep apnea. And he got approval to go ahead and use the hypoglossal, or to implant patients with the hypoglossal nerve stimulator, specifically children between 10 and 21 years of age. These kids could not be obese. Their AHI had to be between 10 and 50, and they had to have had difficulty tolerating CPAP or be trach dependent because of their obstructive sleep apnea. And initially he did 6 patients to look at the safety and efficacy. These children did well, and we'll talk about that. And so then we opened it up to several other institutions. I think there may be 8 or 10. We're lucky enough to be participating in the trial, and we implanted our first child with Down syndrome several months ago now. With some of the younger children with Down syndrome, one modification that has been made, I mentioned that there were 3 incisions. For children with Down syndrome, we found that you don't necessarily need the incision over the, just under the clavicle. You can actually use your bottom incision, the chest incision, and use a lighted retractor and tunnel up and be able to place the stimulator in that way so that you don't have that other incision, because in the initial experience there were a few children that were picking in that incision. And so, but certainly the the preliminary results are very encouraging. In terms of exclusion, we are not including kids that have significant heart disease. And also, while the device is not completely MRI compatible, so you can use it if you can have an MRI of the brain and the extremities, but for a child that needs routine MRI of chest, abdomen, or pelvis, it's not a good idea to implant those kids. The other thing that they're doing in this study, or that we're doing, is also looking on sleep endoscopy. From the adult data, we know that circumferential palatal collapse is not associated with good outcomes, but in Down syndrome, we haven't had to exclude anybody really with circumferential collapse, because the vast majority of these children with Down syndrome do have they have this tongue base or anterior posterior palatal collapse. And on the left here, that's again showing more of an anterior posterior palatal collapse, which does respond favorably in addition to the tongue base. But then here on the right, you're seeing the circumferential collapse. But again, not super common in kids that we've seen with Down syndrome. Okay, so this was the first case report that was published, and I just included it because I think that the figure is really amazing. So this, the first child that was ever implanted with Down syndrome was trach dependent, and you can see with his trach capped on the left, he's just having significant obstruction. This is an epic taken from his sleep study. And then as soon as they turn the device on with just the 1.2 volts, you can see his obstruction disappear. So I think that that's just a really impressive figure. Again, we published data after 60 patients and then after 20 patients. So far, the youngest patient has been 12 years of age, and they found that overall the complications were very minimal. He had some chest wall cellulitis that resolved with antibiotics and some problems with pain control. He did again have one extrusion of a lead that had to be reimplanted, but overall that child did do well. So right now, when we're turning these on, we're waiting a month after we implant them, and then bringing the children back. We're turning it on in clinic, and then sending them directly to get a sleep study, which is a little bit different from adults. The reason we're doing that is because there was one child initially that did develop significant turned on the implant. So the child developed some significant central disease, but luckily they treated her with oxygen, and by her 6-month sleep study, her hypoventilation had resolved. So some of these kids may have significant CO2 retention, so that's why we really want to do the sleep study right after activation. In kids also, we're a little bit slower to turn up, the therapy in terms of the voltage. Initially, we just want to get them acclimated on their first sleep study or two, and then we start to turn it up to try to get therapeutic thereafter. So for the 20 patients for 2-month PSG data, which is again relatively short, really impressive. AHIs from mean of 24 to 3. And really most patients had an AHI less than 10. When we looked at his 6 patients that now have a 1-year data, all these kids had an AHI less than 10, which I would consider surgical success in a child with Down syndrome. If the AHI is less than 10, that's non-severe disease. I'm very happy with that. And so really the outcomes have been great. And also these children tolerate it well. The average use is about 9.2 hours, which is much better than, much of the CPAP where we have trouble getting them to tolerate for 2 to 3 hours. And so I'm very excited. We have our next case, or we were scheduled to have our next case later in May. We have a 10-year-old that we were going to implant with Down syndrome. We're hopeful that maybe we can still do that. But in my own practice, I think that this is really going to be the future for kids that have tongue-based collapse. So in conclusion, we've talked about mild sleep apnea, how there's many different options, but and then for severe sleep apnea, how I personally am biased that maybe considering some multi-level surgery in appropriate cases may improve our outcomes. And then for persistent sleep apnea, really we need a lot more data to kind of help us guide, the direction in the future. So that's all.
Thank you very much, Christine. Good talk. Thank you again. Have you have access to the chat? See if you have some questions in the chat.
Oh, I do. Okay.
Let me see.
So thank you guys, and we'll see you again. Dr. Baldessari could not join us, but for the next 2 or 3 days we will have some live meetings for you, and it's going to be very, very interesting. Thank you, and I'll see you tomorrow. Thank you. Bye-bye.